if you are opposed to being recorded, just disconnect from the session. We use the recordings on our for quality improvement. They're stored on our Canvas page as well as on our YouTube channel for future reference or people to go back and review. Participation in ECHO is always helpful. That's the way that we learn who is on the call, where everybody is from, how our providers can get to know each other. So please ask questions after the didactic, put them in the chat on Zoom. Another way to continue on with participation is doing case narratives. It's a great way to solidify information, work through a case that you're struggling with, or just get information from others about what they are doing with certain things. So if you've not done a case and you have one, please reach out to us. Anytime we're talking about any information, please remember to protect individual privacy. So avoid using first, middle, last names, any identifiable information. If you're unsure about that, please reach out to one of our hub members. They all have an asterisk in front of their name. If you can also take a minute and just rename your profile with your discipline or the place that you work. We have a lot of different states on the call, and so it's always helpful to know where our colleagues are working at. Raising your hand, these are probably features that you already all know how to do since we've been in the world of Zoom for so long. But if you have any questions about how to raise your hand, here is how you can do that, as well as just put your your question into chat. Pre-registering for the ECHO sessions just receives those notifications ahead of time and our weekly announcements. So you can do that by emailing earlyecho@usu.edu. The way that you can earn a certificate of attendance is to complete the surveys after the session. We mail those out once a month, and so that's how those credit for attendance come in. We store everything on our Canvas page. So if you need access to the Canvas page, please reach out to Early ECHO. You can reach out directly to kurt.phillips@usu.edu. And we'll get you set up on that. Again, if you have a case that you are interested in learning more about or problem solving with your colleagues, please reach out and consider doing a case presentation. Kate Bennington, who is one of our hub members, also reaches out to see if other people would like to do a case. So RedCap is where our surveys come from. They sometimes come through your spam or junk email folders, so make sure you double check on those. And then just take a minute and follow us on social media. We try to share useful information, things that have been shared in past and current ECHO sessions, as well as other pertinent resources. So I am really excited to turn the time over to Kevin Baird, who's going to be talking to us about the newborn screening.
All right. Were you able to hear me?
Yep.
Okay, wonderful. Thank you for letting me come and talk about newborn hearing with you for a bit. I normally, when I do presentations, I do them with pediatrician groups, and I don't have as much time as I have been designated today, so I usually try to talk really fast. So if I get going too fast and you have a little extra time, I guess you have extra time for lunch break or whatever you're on today. Thank you so much for being here. And I'd like to thank Pat Boyle, my colleague here. She's the one that suggested that I could present today about newborn hearing screening. It's something I've been involved with for a number of years, and over 22 years now that I've been a newborn hearing screening participant in that. As an audiologist, I have a master's and bachelor's degrees from Utah State University. So it's nice to see the old main insignia there on the USU campus. It's such a beautiful place, and I love it. And I have a doctorate in audiology from Salus University. Back in the day when I was doing my doctorate, online learning was really, really new. And so I was in many meetings like this in the early 2000s where, with the pandemic and everything, it's really created a different space for online learning. And it's so great we have this ability to be together today. I'm going to present here with the slides here on the side so I can and see where I am in the presentation. So hopefully that's okay. Dr. Shannon Winnick at the Utah Department of Health has created some of the slides I'm using in my presentation today. So I want to acknowledge her. The slides that are a little bit purple in color, or some that she has put together that she's allowed us to use when we do have presentations. So want to give her special thanks. I'm going to go ahead and we're going to play a little video here. We check the sound. Hopefully this sounds okay. And you can see this okay.
Giving your baby a sound beginning. Have you ever wondered, how soon will your baby learn to communicate? Even before birth, a baby hears the rhythms and tones of sounds from the outside world. Newborns are especially sensitive to the sound of the human voice. As this baby watches his mother's face and hears her speak and sing, he is already learning to communicate. His hearing system and brain are being shaped every day by the words and sounds around him. A baby's ability to communicate and bond with caregivers develops rapidly during the first months and years of life. By about 3 months of age, most babies will smile when spoken to, and by 6 months, they will begin to babble and imitate simple sounds. And by 1 year, most will say their very first words. How does your baby hear sound? As this mother's voice reaches her baby's ear, the incoming sound causes the eardrum to vibrate, which then moves 3 small bones in the middle ear. This movement stimulates thousands of tiny sensitive hair cells in the inner ear. From the inner ear, the sound signal is carried along special nerves to the hearing centers of the brain, and the baby experiences the sensation we call sound. How can your baby's hearing be checked? Thanks to advances in technology, we can now check a baby's hearing shortly after birth. Your healthcare staff is concerned about your newborn's hearing because 1 out of every 300 babies is born with a hearing loss. Children who cannot hear clearly will often have trouble learning to communicate. That's why it is important to check or screen each newborn's hearing using one of 2 safe, simple, and painless procedures. Let's watch an example of each. One method is called OAE, or otoacoustic emissions screening. In this process, a trained screener places a small earphone in the baby's ear that emits a series of soft sounds. The inner ear typically responds to these sounds by producing echoes called otoacoustic emissions, which are analyzed by the screening equipment. Another method is called AABR, or Automated Auditory Brainstem Response Screening. In this process, a trained screener places Band-Aid-like sensors on the baby's head. As soft sounds are played into the baby's ear, these sensors analyze the brain's response to the sound. No matter which method is used, in a few minutes the screening is finished and the result is displayed. What do the hearing screening results mean? Most babies will pass the hearing screening before leaving the hospital, but some will be referred for further screening or testing. You and your baby's doctor will be contacted if you need to bring your baby back for more screening or for diagnostic tests performed by a hearing specialist called an audiologist. Most infants who need follow-up testing will pass. And if you are asked to return for follow-up, don't delay. Remember how important communication is to your newborn. You'll want to know if your baby can hear the words you speak and the songs you sing. After the hearing screening or testing is completed, talk with your healthcare provider about the results. Remember that passing the hearing screening is the first step to ongoing hearing health. Learn more about how a growing baby responds to sounds and enjoy watching your baby learn to communicate with you. What should you do if you have questions about hearing screening or about your child's hearing? You can start by reading about newborn hearing screening and getting ideas on how you can help your baby listen and learn. Check your information packet for brochures on hearing health or request information from your healthcare provider. Every child needs a medical home, a healthcare provider who works with you to care for your baby's overall health and development. If at any time you have questions about your baby's ability to hear or speak, don't hesitate to ask your doctor about referral for a hearing test. In fact, your baby's hearing should be screened at birth and again throughout childhood. Let's review the most important things you will want to remember. Remember that every newborn should be screened for hearing loss. Hearing screening is quick, safe, and painless. If more testing is needed, have it done right away. Finally, talk to your doctor about your baby's hearing and language development. We care about the health of your baby. Hearing screening is just one way your healthcare staff works together with you to make sure your baby has a sound beginning.
All right, thank you so much. That's a dear video to me because I was involved with the production of that video. It looks old. It is old. It's probably over 20 years old now. But I was the audiologist that was putting the little probe in the newborn's ear when they said, check with an audiologist if you have concerns. So that was me many moons ago when I had brown hair. We filmed for about 3 hours and I got about 5 seconds in the actual production. So early hearing detection intervention, the Joint Committee on Infant Hearing has come up with a guideline that newborn hearing screening is to follow. The recommendations from the Centers for Disease Control are to have a hearing screen before 1 month, the diagnostic evaluation before 3 months, and early intervention started before 6 months of age. There have been many studies done that have suggested if a newborn is identified early that their speech and language can progress very similar to their normal hearing peers if we meet those guidelines. In the new Joint Committee on Infant Hearing, it suggests that those that are meeting the 136 guidelines, that we look to a more current target of 1 month, 2 months, and 3 months. So getting that early intervention started by 3 months of age. And that's that's a goal that we've been working on and trying to do as much as possible. One of the reasons for that, as you look down there where it says second objective audiological testing can be completed without sedation during the natural sleep that occurs when an infant is young enough to sleep for prolonged periods of time. One of the things that we do once the newborn is identified, we do a more comprehensive hearing test called an auditory brainstem response. It's a diagnostic test, and that works so much better when the newborns are asleep. So we like to, instead of waiting, we like to do those tests as soon as possible. Number one, to get the information to the parents as soon as possible, and number two, to really take advantage of that time where the babies like to sleep a lot. In Utah, we do what we call the 1/3, 3, 6, where we screen the newborn, have an inpatient screening. I have another slide that shows that. The inpatient screening is done in the hospital, and then we like to bring babies back by about 10 days of age, because in Utah, there's a mandate for a cytomegalovirus test if the babies fail the outpatient hearing exam. And so that testing needs to be done by 21 days of age to know if it's congenital from inside in the womb. So our guidelines that the State Department of Health asks us to follow is the 1/3, 3, 6. Before newborn hearing screening, children were being identified at, if you look at this is in months, 30 months, 25 months, 31 and 35 months on those studies in the past. Now, after newborn hearing screening has been put in place, average between 2 and 4 months is the age of identification of those newborns. And Christine Yoshinaga Itano is a very well-known, well-respected researcher in regards to these guidelines and how they are helping kids. And one of her studies, suggests that if the child is identified early, that they can be well ahead or close to their normal hearing peers, well ahead of those that are later identified, for sure, in regards to speech and language development, educational development, of course. So you saw a little bit of an OAE and an ADR screen there. OAE measurements are sound sent into the ear canal. It goes through the auditory system into the cochlea or inner ear. The cochlea has a nerve endings that vibrate and creates a response that gets sent back out of the ear. And we measure that with a microphone. And with the ABR, AABR stands for Automated Auditory Brainstem Response. With an automated auditory brainstem response, we have electrodes or electrode sites where we present a sound that's one level of loudness, and we see if we can get a pass-through from that screening. And that gives us an indication that the auditory nerve is functioning appropriately. There's a condition that we're trying to rule out by using the auditory brainstem response screening. It's called auditory neuropathy spectrum disorder, ANSD. And there are cases that we see every year where the neural integrity of the system is damaged in some respects. And so the inner ear functions appropriately, but the brain doesn't get the signal processed how it should, and causes some pretty bad distortion. They've had some videos out. I'm sorry, I don't have one today, where it kind of presents what a person with auditory neuropathy hears, and it's not the way that you and I would hear a signal coming from the auditory system, and it makes for some frustrating times for the parents and the child learning speech and language with that. So we try to identify those early so that we can get on that path of helping them with early intervention services if needed. So when do we use the OE and the ABR? Most of the time we use the otoacoustic emission screening in the well baby nurseries. There are occasions where we will do the ABR screen or an OE and ABR screen in the well baby, and that would be for babies that have family history of early child hearing loss. We also use that for Down syndrome babies and other conditions where we like to do a little bit more thorough check of the auditory system. We want to follow those babies that may have some conditions that may need some additional auditory help. So we screen by ABR on those babies too. In the NICU, the Joint Committee on Infant Hearing Position Statement 2019 recommends that all NICU babies have an ABR screen, that they be checked for by ABR, and that's to make sure that we're not missing any auditory neuropathy cases in the intensive care units. So we have the two stages of the hearing screening. We usually try to do our initial hearing screening 12 to 24 hours after the baby's born. And if the babies don't pass, sometimes that's due to vernix or debris from the birth in the external ear canal, or from middle ear fluid that's just prolonging in the middle ear space. Babies are in fluid for a long time inside the womb, and that's a very common thing that needs to kind of clear out, dry out. So if the parents are there for multiple days, we will try to do a hearing screening about once a day to recheck that. If they are discharging, then we schedule a follow-up, usually within 7 to 10 days to check on those babies. So the outpatient screening, if they pass, we have parents monitor speech and language development. And also, if there are any early intervention people or anybody else on the team, that's certainly something that as we look at getting people eligible for services, that hearing, I believe, should be one of the things we check, make sure that we have a good auditory system to make sure that we can learn speech and language and have good educational outcomes. So primary care physician, I'm going to show a slide in a minute about that and how they can help us with that too. So if they fail, the pediatric audiologist would provide a diagnostic ABR. We send communication to the newborn's pediatrician, letting them know that the baby has failed outpatient screening and that they need to do cytomegalovirus testing by 21 days of age. And that is accomplished by urine or saliva. If they do a saliva sample, that it needs to be 2 or more hours after feeding so that there is a possibility of contamination from the mother's breast milk. So here's the mandate in Utah. All babies who fail 2 newborn screens must be referred for CMV testing before 21 days of age. And this also applies to NICU babies that if they have their first hearing exam after 14 days of age, then they are checking for cytomegalovirus if the baby fails the inpatient hearing screen. One of the things that we are doing in Utah is we're referring to Dr. Albert Park and his group, and they look at trying to double check and make sure that if they do a saliva sample, they'll a lot of times do urine sample, double check, make sure that it is really CMV. Then they're referred to infectious disease so that they can be followed and monitored. There is some antiviral medication that they will give the child to see if they can delay or cause the hearing loss to not progress. One of the things with cytomegalovirus is that hearing loss can sometimes be unilateral on one ear, and it can progress and to a more significant hearing problem over time, and it also can progress to the second ear. So we want to watch those babies a little differently. Cytomegalovirus is the leading non-genetic cause of hearing loss in infants. And it's estimated about 20% of newborns that have hearing loss diagnosed, the cause is cytomegalovirus. So it's a pretty prevalent condition, cause of newborn hearing issues. The Joint Committee on Infant Hearing really recommends that there's ongoing surveillance with the pediatrician or the medical home. I just wanted to, make you aware that that's really something that we should always be doing, is surveilling these kids over time and making sure that the hearing doesn't change, because certainly there can be issues with even just ear infection or middle ear fluid. Certainly can affect how well that child is able to hear and advance educationally. One of the things that we have that the American Academy of Pediatrics has preventative care maintenance recommendations, and one of those circled in red there is hearing. And as you can see, there's a lot of different timelines that they recommend that hearing be checked and looked into if needed. They also, on the Joint Committee on Infant Hearing, recommends that even if a baby is past newborn hearing screening, if there are auditory or communication skill developments that are delayed, that they should be referred for an audiological evaluation. And they also mention that if there's parents or caregivers who express concern regarding communication skill development, that they also be referred for an audiological evaluation. And that's something that we sometimes struggle with in regards to having pediatricians send children directly to have a hearing test. They may wait it out for a while. And my response to anybody that ever asks about that, that's got a child and they're concerned, is go ahead and let's get your concern checked into right now and get a hearing test done. And just make sure that it's not something that's developed over time. Risk factors for early childhood hearing loss. This is from the Joint Committee on Infant Hearing Position Statement. There are a number of different timelines that we look at in regards to recommendations. The one for cytomegalovirus is a 3-month follow-up. And a lot of times the recommendation is 3 months till about age 3, because they found that most of the progressive hearing problems are through age 3. You can see there's a number of other conditions that it recommends that we do 9-month follow-ups. On the babies that are in the NICU more than 5 days, automatic recommendation for a follow-up at 9 months. By that point, you can sit a child in a parent's lap and have them turn towards the sound through the speakers and get a little bit of a behavioral response to sound. That's always the best. Ideally, is to be able to know exactly what that brain is processing and getting the head turn, and I'm getting responses from the child is very helpful with that. So, but the different time frames there for different conditions recommended there. This is kind of a little bit different risk factor. This comes from one of our State Department of Health recommended guidelines for NICU and everything. So there's a little bit of difference there. I wanted to point out number 9 here. It says there are over 400 syndromes that have been identified with atypical hearing thresholds. And so there's a lot of different things that could be at play that we may not know unless we refer a child for a genetic consultation when we do have hearing issues. Now, all that says 400 syndromes, and I don't believe that genetic testing that they do checks for 400. I think they may be into the hundreds, but we always recommend when we're suspecting a permanent childhood hearing loss that we look at genetics and make sure that genetics are looked at, because there certainly are some things that happen in regards to that. So this is just a diagram of the recommended timelines, the recommended way that we approach things. So we go from inpatient, outpatient, refer. We check for cytomegalovirus and do a diagnostic test, and then refer for early intervention. And that's just kind of a flow chart of the recommendations for the state of Utah. One of the things that I like to give out to parents is this roadmap for families. Kind of gives them a little checklist of things to look at and timeframes to do those things in. And on the right-hand side, before 6 months, enroll in early intervention and have regular visits with the pediatric audiologist. And then evaluations, ophthalmology, and genetic specialists, and then other specialists if needed, if there's suspected other things going on. So I like to give that out to parents all the time. This is from the American Academy of Pediatrics and the National Center for Hearing Assessment and Management in Chatham, which is on Utah State's campus there. Carl White is the director there. So one of the things we do give out to parents when we're looking at the cytomegalovirus is a brochure from the State Department of Health. The state got some funding when the CMV law was initiated to create some educational materials. This is one of them. And then this is available on the Utah Department of Health website we look at. So let me just go over some data. This is from the last year or so, Intermountain Healthcare in regards to our newborn hearing screenings and some things here. System-wide, we tested 26,600 babies or so. 152 of those babies failed the outpatient screening follow-ups. And so they were tested for cytomegalovirus. Of those, CMV 13 tested positive for CMV cytomegalovirus. And the diagnostic tests that we did, this is what results we found this past year. We had 22 sensory neural hearing losses, 4 hearing losses that were what we call mixed. That's a sensory neural component on top of a conductive component. So that would be like, say, somebody has a hearing loss and then they have an ear infection on top of that, or they have problems with the bones in the middle ear, or something like that, that would cause us to have sound not conduct through the system like it should, but also have a permanent part on top of that. Fluctuating conductive hearing loss, 25 there. Those are the ones that have fluid in the middle ear space that hopefully the majority of those will clear up over time, but sometimes those fluid in the middle ear cases, if they stay for long periods of time, it can work itself into a permanent hearing problem. So we want to continue to follow those children. And if you're getting in some of those kids in early intervention, I would just check in regards to, has hearing been checked recently, and continue to check on that when you have your visits. 13 permanent conductive hearing losses, that would be like either problems with the bones in the middle ear, or it could be what we call an atresia, where the ear canal is closed off and sound just can't get through into the inner ear to send information up the auditory nerve to the brain. And then 10 neural, that would be the auditory neuropathy spectrum disorder type situations where the auditory nerve isn't sending the signal like we would hope to process it. I thought this was a very interesting study. It suggests that 0.7% of all children are infected with cytomegalovirus at birth. And if we run some numbers for Utah last year, if we ran 0.7%, that would be 329 babies that should test positive for cytomegalovirus. Unfortunately, that is not a universal screened condition. And so that's, we're quite low with our identification of cytomegalovirus. And in Intermountain, we had the 26,000 babies, and that would suggest 186 babies that would have cytomegalovirus. Now, if you looked at the numbers up top, we tested 152 babies, but we only identified 13 that had cytomegalovirus. So if you go off statistics, 186 babies minus 13, you got 173 babies that may be out there that we don't know of that have possible cytomegalovirus as a condition. And that may turn into a significant hearing problem over time. They did a study recently with the pandemic going on, and they found that the amount of kids with cytomegalovirus in the last 2 years has dropped a bit. It was 0.7%, and now it's at 0.4 in the state of Utah, at least from what we could gather from the testing that has been done the last little while. And I think they associate that to the people wearing masks and having better hand hygiene and things, that it's not passing that as much as it had in the past. So there certainly are a lot of other possibilities of why why a newborn may not pass the hearing test and what causes the hearing loss. Besides cytomegalovirus, there's certainly a lot of genetic conditions, of course. Connexin 26 is one of the big ones that they test for. A number of years ago, I went to a conference where Walter Nance, who's a geneticist who works with hearing loss all the time, and he basically said that if you check for CMV and you check for Connexin 26, you'd probably catch about 80% of all causation of hearing loss. But that leaves that 20% for all the other conditions that may be going on. So I would just, as early interventionists and people that work in the field, I would just encourage you to continue to monitor and watch these children for a need for hearing evaluation and throughout childhood. It's estimated 1 to 3 babies per 1,000 at birth, and that number jumps to 3 to 6 babies per 1,000 by about age 5. So there is definitely some delay in onset of problems with it. And that's what I have for you today. Any questions?
If you have any questions, you can just go ahead and unmute, or you can also put them in the chat and we will read those. So I have a question, Kevin, on with CMV, what is the leading cause of CMV?
Well, I think more than anything, it's just sharing stuff with your baby, kissing your baby on the lips, maybe not properly washing your hands, and your child has CMV when you're changing a diaper. I believe in the recommendations they have right now, it's just really, really good hygiene while you're pregnant. And a lot of times the mom just thinks she has a cold, and what she has is this little virus that can affect hearing. It also can affect a lot of different things. Intermountain has a cytomegalovirus protocol where it checks for CMV if there are a number of different things, such as small for gestational age, IUGR, stuff like that. They will check to make sure it's not CMV related. But I think that's the main thing is have a good hygiene while you're pregnant.
And then a follow-up question. So women in childbearing years, we know that whenever this is talked about in our early intervention program, we start getting panicked about that. Is there a high contingency risk? Should they avoid being around that?
Well, I think it's just be careful with how you kiss your baby when they're slobbering and stuff. It's not to get a little bit of that, but it's just good hygiene more than anything.
Oh, okay. And then Kate put a question in there. She says, what are the two conditions that accounted for 80% of hearing loss? So CMV and what else?
And connection 26.
And then Kurt, had you come unmuted to just ask that question, or Pat,
Yeah.
I see your.
Yeah, it was me.
26 is
yeah. Sorry, Kevin.
It's a genetic condition where it has a lot of different ways it'll manifest itself in regards to hearing issues, but it's just a gene that's part of it.
Yeah, I was going to say that we've had over the years in EI, infectious disease people come and consult with us, and it's basically universal precautions. Wash your hands before you eat. And a lot of the families that I followed who end up having a CMV positive child, they said there was no indication. Their kid was in daycare, had a snotty nose, and they did what Kevin said, kissing on the mouths, all of that. Just being very, very careful when you're pregnant.
And then there's another question that says, are there hearing screenings done for children who need pediatric ICU care who are on prolonged oxygen, say the range of over 6 months, but not yet 2?
Yeah, those kids, and specifically, I'm thinking of ECMO. When I'm thinking about that, those kids, I don't work at primary children, so a lot of those kids that are on those extended things where they're working with the ECMO are at primary children's, and they certainly do get a hearing test at some point. Sometimes they want to make sure that they're medically stable enough before they do the hearing test, so it may be a little bit longer for those kids. And some of those kids that they identify at primary children's are actually doing some fitting of hearing aids and things on them while they're still in the hospital. I remember having conversations with Adrian Johnson and Michelle Bunker up there at primaries, and they're always doing that. Or they're trying to get to those babies as soon as possible to give them that auditory stimulation if they need it.
And then her follow-up question is, yes, at primaries, thank you, but hoping does it happen prior to return to their home state? So if they're at primaries and then going home. Teresa, if you wanted to come unmute if I didn't ask it correctly. I guess I did, so.
Janelle, this is Rebecca Foster. Can I just pop in on that?
Uh-huh.
A lot of times we'll get referrals out of an acute situation, and The child may not qualify for early intervention, but they might be appropriate for being followed by right track. And at least in North Dakota, the right track providers are trained to do those hearing screenings. So that would be another method of follow-up for those families.
So Rebecca, and what is, did you say right track?
Yes, right track. So that's developmental screenings that can take place up to 6 times per year with the family.
So Teresa's in Montana. I don't know if Montana people know if they have a right track or a
they should have it. It's a federally, it's basically the child find program under IDEA Part C. So they might call it other things in other states, but basically it should be a free screening program available in the state.
And then Kevin, do you know if primary, before they leave primary, did they get one prior to
Yes, they should get one prior to discharge. And if they don't, if somehow they don't, they certainly would try to arrange for that to make sure it happens.
Can I just say that a lot of the issues with the older kids, Kevin, at primary, is that a lot of them are trached, they're on oxygen.
Yeah.
And it's so hard to test those older kids. It's really hard.
It is. And part of that, again, comes down to having muscle activity going on, which affects how the little electrodes are able to measure things. So if there's myogenic activity going on, that makes it a little more difficult. That's why I think they try to get them as early as they can when they're stable. Try to get that identified as quick as they can.
Any other questions that anybody has for Kevin? And then Ellie Smith shared in the chat the roadmap for hearing loss and the risk factors that Kevin shared with a link. So I will also share those out with everybody and put those on our Canvas site if you haven't gathered that from the chat. Well, if there are no other questions, Kevin, thank you so much for taking the time and sharing that information with us. That was just some great information and knowledge about it. And Rebecca Foster is who's going to be sharing our case presentation today.
Presentation mode. Okay, can everybody see that?
Yep.
Okay. So I'm Rebecca Foster. I'm an occupational therapist and I work with the Minot Infant Development Program in Minot, North Dakota. And we cover a region of our human services zones here in North Dakota. So a pretty wide range. And then we're based out of Minot at Minot State University. So the case presentation I'm bringing to you today is a child that we see in the early intervention setting. So the family receives visits in their home or community setting sometimes at their choice. And this little guy is a 2-year-old who he turned 2 in August. And he was born without fully formed ears. So it's bilateral microtia atresia. So if you look at him, he's got like the tip and the bottom of the ear, but no ear canal. His cochlea is intact, his auditory nerve is intact. So he wears bilateral bahas, which is the bone anchored hearing aids. And the most recent audiological testing they had showed that he could hear an average range of sounds with the Bahas on. And he does a really good job actually of keeping them on during the day. And he will, even in the morning when he gets up, he will sign to his mom if she doesn't put them on right away. So other than bath time, and maybe I think she might take him off sometimes at mealtime if he's eating something really messy, but otherwise he's wearing them most of the day. This little guy lives in a 2-parent family with an older brother who just recently turned 5 years. And mom stays at home with the boys. The family is Native American. Mom has stated on a few different occasions that she does struggle with anxiety, but both parents are very involved. And he receives visits 2 times per month from myself, and then he gets some speech consults once a month. And then he also has a teacher of the deaf who comes into his home twice a month. And when we started services, that was kind of mom's choice. She felt that anything more than that would be overwhelming for her. So we alternate visits so that typically he has either myself or the teacher of the deaf coming in once a week. So the biggest concerns right now for this little guy is that he's over 2 now, and I would say over the past 6 months or so, he's made pretty minimal progress with his speech development. He has a combination of about 10 words and signs, and mom feels that his understanding of language continues to grow. She notices that when he's out in public, he can be a little bit overwhelmed by the activity around him. Like if we were to go to the play area at the mall per mom's request for a home visit, at times he gets overwhelmed by that and he wants to get away from the other kids. But at home, when nobody's there with them, she reports that he's pretty vocal. He walks around making some sounds, is kind of becoming more aware of his mouth, and will like sometimes, bring his lips together. But he just isn't adding either words or sounds at a very quick rate. He's kind of been stagnant as far as adding new things. The biggest change has been that he's become more spontaneous and independent with using the signs and words that he has. So he'll sign and try and say more. He does all done. Let's see. I'm trying to think off the top of my head. Mama, dada, bye-bye. So just kind of some of those early words that you expect kids to learn. Another thing that is an area of concern with him is that he really has an open mouth posture. Chin is down, lots of drooling throughout the day. His mom reports that he will soak 4 to 5 bibs a day that she keeps on him. And he just recently had an annual visit to the genetic clinic follow-up, and they didn't say anything in the visit. And then mom said they got a letter that was just kind of summarized their visit after the fact. And the letter made a statement about that he may have a smaller than normal chin or lower jaw. And mom didn't really know what to make of that, wasn't really interested in any follow-up conversation with the doctor about it. But she did mention that kind of the open mouth posture and maybe even a little smaller chin was something that seemed to be in Dad's family, although Dad doesn't currently have that issue. So that was something that kind of came out recently that was interesting, and I'm wondering if it could maybe explain some of the open mouth posture. So goals are to increase the number of words and signs that he uses for communication during daily routines, and then to decrease the drooling or improve that oral motor control and oral posture when he's at rest. Barriers are just not sure what role genetics has. I kind of did some digging after Mom shared that information with me, and so I kind of have a question mark in my head about possibly Treacher-Collins syndrome. That's one that kind of popped up in my digging, and I don't know. Yeah, they would have to do more genetic testing, and mom's not really interested in that at this point. The other thing is, as early interventionists, we're not really supposed to be referring people to private therapy services, but we have had a couple conversations about that recently, and she's just not really interested in pursuing anything. And then the cause of that could be finances. Mom is a stay-at-home mom, and so they're one-income family, and so that might be a barrier that she just doesn't feel comfortable sharing. So things that we've tried between the speech therapist and myself, we've shared different strategies, little exercises or stretches that she could do with him, ways to increase sensory input to the face and oral structure through, you know, maybe like stroking with a washcloth, using a vibrating toothbrush, using different play activities. And so far, I would say we've kind of had, I don't know that we get a consistent follow through from mom, and it doesn't seem to be as big a concern for her as it is for the people working with the family. The teacher of the deaf has brought up to me a couple times, like, what are you guys doing to deal with this? And, how, you know, what are you working on? And, you know, you really need a goal for that. Well, our goals are family driven. And so while we can work on it, if it's not a big concern for mom, we can't, you know, force them to have a goal in their IFSP for it. So, and then, you know, recently, as we were talking about the genetic thing, the speech therapist did, you know, kind of bring up that conversation. Have they considered, you know, did the doctor say anything about private speech therapy or anything like that? And mom feels that they're pretty content with what they have provided for them right now. So for our group discussion, kind of what we would be looking for would be some more strategies to recommend at home, things that would maybe be motivating for family and with this little guy to work on some all motor things, and then additional resources maybe that would be low cost or no cost to the family. And then, you know, should we pursue discussion around possible genetic factors? You know, does that look like me having a conversation with a primary care provider, but I don't really feel comfortable going around mom if she's not that concerned about it? Or do we kind of wait for an opening and have that conversation again with the family? So we'd just be curious to get some input on that.
Okay, so before we go into breakout groups, we're gonna give a few minutes for others to ask some clarifying questions to Rebecca. There's one in the chat already that says, what does his palate look like? What does his tongue mobility look like? Can he bite and chew?
So he bites and chews. He doesn't drink from an open cup yet. I've not felt inside his mouth to feel his palate. Definitely has lower tone with his tongue. His tongue, I wouldn't say protrudes, but it's towards the front of his mouth. And we the speech therapist and I had talked about, I don't know if any of you are familiar with myofunctional therapy, but thinking that, you know, something like that might be an appropriate type of intervention for them to try. But it's tough because I don't want to push mom to do more things than she's ready to try. But at the same time, we're like, okay, this little guy is over 2 now. And so what more could we be doing so we don't lose any time, you know, really follow that early intervention approach.
And then the other question is what does he drink from?
He drinks, so we've gotten him as far as a straw top sippy. When they first went off the bottle, it was, you know, the soft spout that was very much like a bottle. So now we've moved on to the straw. He does use a pacifier. Mom has been working on waking him off of that, so that's decreased to the point that He can go chunks of time throughout the day without it, and then primarily uses it for nap time. Yeah.
I have a question, Rebecca. You've mentioned the low tone in his mouth. How is his overall tone, and specifically his core and just kind of overall postural control?
You know, it's probably like, I did get to go with them to the park this summer, and that was really interesting to see him navigating some different surfaces versus how he looks in the home. So he was a little more unsteady on his feet. Took some repetition of going up some steps or stepping over things to do it without having to crouch down and hold on to something. They have been working on stairs at home, so he has just recently mastered going up and down the stairs, holding the wall, going by himself. So that's a pretty new skill. And you know, it's interesting because like he's always been just a super chill kid. So, you know, you're always like, well, is this just a personality? Like he's more of an observer, or, you know, is it just this overall tone? And yeah, so that's the thing that I think about.
So with his posture, is he sitting in a slumped posture, which then throws you into this forward head, open mouth position, or does he sit up pretty well and then still have the open mouth?
I would say he sits up pretty well and still has the open mouth. Mm-hmm. Yeah. And, you know, we did his annual evaluation in May, and then the speech therapist and I were kind of talking like, do we see cognitive concerns? But he's not, like, I would say he's fairly on step cognitively. His understanding of things seems like it's continuing to progress. So yeah, but he's just kind of stuck on his expressive communication.
Okay, we're going to take one more question and then we'll do our breakout groups. So has he had a history of illness?
No, other than, you know, just regular kid colds once in a while. He's been pretty healthy.
Okay, so we are going to move into breakout groups. If you'll take a minute to do some introductions of who's in your breakout group so we can get to know each other, and then we have put the questions that Rebecca has in chat. We will stay in our breakout groups for about 20 minutes and then we'll come back to the full group. So you should see that you have been asked to move to your breakout groups. Nicole and Tori, do you see a thing to join the breakout group? Tori, do you see your breakout group? We're just waiting on a few people. I think maybe we have everybody back. So Pat, do you want to share one thing from your guys' group? You're on mute.
There was a lot of talking. I think the interesting one was the financial and reaching out to see if there was some pro bono. And we had Rebecca in our group. So she said there was actually like a group at the university, I think she said. So just sort of exploring that way to get the financial burden away.
That's a great one. So Shelby, I have you in a group want to share one thing from your group, or whoever was in your group you had take notes?
We have a lot of suggestions.
Well, good. Just share one and then we'll put the
Let's
rest on our recommendations.
I think one of the biggest things that we talked about right at the beginning was like looking at that anatomy, maybe encouraging a visit to an ENT for just any kind of oral structural issue or possible like obstruction that's making nose breathing difficult and leading to that oral posture. That was one of the big things we talked about right at the beginning of breakout groups.
Oh, awesome. You guys sound like you guys have some great suggestions and strategies. So if both groups will send those recommendations to Kate and we'll compile those, they will always, those recommendations are always on our Canvas site. So you guys can always go back and utilize those for past clients, current clients, just hearing what everybody else said on that. Next month, we are having Diana Childress come and present to us about the adult learning principles that every early interventionist should know. She's a nationally renowned speaker, so it's going to be a great presentation. She is on the board of Division of Early Childhood. So really lucky that we have her coming. That will be October 5th at noon again. And then if you have case presentations that you want to share or just discuss about a case with all your colleagues, please consider sending in a case narrative. And if not, we're going to let you guys go 5 minutes early. I can hear my echo. I have Jordan. He works in my office and I keep hearing me echoing. That is so annoying. So have a good rest of your day and we'll talk to you later.